Most often students get confused with Langhans and Langerhans cells. And these neutrophils should be seen in all the layers. I wanted to know the stages of lobar pneumonia. So what are the 4 stages? Hi everyone. Welcome back to this short tutorial from Pathology Made Simple at iLovePathology.com. Starting from this session, I will be discussing salient features of microscopy of all the slides which you encounter in your practical examinations. This would help you in revising practical slides. So the first slide I'll be discussing is fatty change. Before we understand what you're supposed to see in microscopy of fatty change, let me try to illustrate what you're supposed to see. You should know what is microvesicular change and what is macrovesicular change. Microvesicular means you find these lipid droplets around the nucleus of the hepatocyte. Whereas macrovesicular are these lipid droplets only, but then they are enlarged lipid droplets. Over a period of time, these enlarged lipid droplets push the nucleus towards the periphery. So that is a macrovesicular fatty change. So this is what you're supposed to see in the fatty change of the liver in microscopy. So this is a hepatic parenchyma where you can note that these are the vacuoles and these vacuoles are macrovesicles. If at all you find those vacuoles within the hepatocyte around the nucleus, those are microvesicular fatty change. So this is a higher power magnification showing the nucleus here and then those foamy tiny little vacuoles in the hepatocyte, microvesicular fatty change, and these larger fat vacuoles are macrovesicular fatty change. If you want to illustrate this in the examination, please note that write a central vein, write chords of hepatocytes and then demonstrate microvesicular as well as macrovesicular fatty change. How do you demonstrate microvesicles? Write a hepatocyte and then you draw these clear vacuoles. These are lipid-rich vacuoles in the cytoplasm around the nucleus. Note that the nucleus is not displaced. Whereas in the macrovesicular hepatocyte, you find that the fat droplet is pretty huge. It displaces the nucleus towards the periphery. It looks like an adipocyte basically. Okay, so this is how you need to draw the fatty change of the liver. Before I conclude the fatty change of liver, please note that you also should know what are the special stains used to demonstrate fat. These are some of the special stains. I'll show these with illustration. Sudan 3, which stains the fat yellow-orange. Sudan 4, which stains the fat orange. Oil red O, as the name says, it stains the fat droplets red. Osmic acid, it stains the fat droplet black. Sudan black B, as the name says, it stains the fat droplet black. This is your H&D slide for comparison. So that is all about fatty change of the liver or fatty liver. The next slide which you should know is acute appendicitis. It's a very easy slide for you to identify in your practical examination. Just look at the slide. There will be a very small circle-like thing. That is the clue for you to say that there's a tubular structure is actually an appendix. So what do you see in appendicitis in your slides? So you can make out the entire section of appendix in the scanner magnification. You can see the exudate in the lumen. Okay. The mucosa is ulcerated. That's the ulcerated mucosa you can see. You can even see the submucosa in this magnification. That is a muscularis propria and that is the serosal aspect. So the most important identification feature of appendicitis is demonstrate the presence of acute inflammatory cells, because you're looking at acute appendicitis, right? What are those acute inflammatory cells? They are neutrophils, and these neutrophils should be seen in all the layers, particularly in the muscularis externa. Okay, so that's the ulcerated mucosa. So this is a submucosa where you find lymphoid follicles normally. That's the exudate in the lumen. Okay, so you can see that abundant inflammatory cells. At this magnification, you can see those tiny little dots, right, in the muscularis externa. Okay, these tiny little dots are inflammatory cells in the muscularis propria, and in the higher magnification, you can easily make out that these are actually neutrophils. So, demonstration of neutrophils in the muscularis propria is the diagnostic feature of acute appendicitis. You have to write that. So, if you want to illustrate appendicitis, you can do this. You can write ulcerated mucosa, You can show some, exudate in the lumen, show the lymphoid follicles in the submucosa, and the most important thing is that write all the acute neutrophils in all the layers. That's why it is called as transmural acute inflammatory cell infiltrates. The diagnostic feature, as I told you, it is the neutrophilic infiltration in the muscularis propria. If the disease is severe, the neutrophils can extend into the serosa as well, and it can cause periappendicitis. So that's about the microscopic feature of acute appendicitis. Moving on to lobar pneumonia. It's another important topic in your practical examination, lobar pneumonia. So what are the microscopic features of lobar pneumonia? For you to understand the microscopic features of lobar pneumonia, you need to know the stages of lobar pneumonia. So what are the 4 stages? The stages are stage of congestion, stage of red hepatization, stage of gray hepatization, and stage of resolution. Okay, hepatization. The word hepat means the lungs look like a liver and feels like a liver. It will be formed like a liver. That's why it's called hepatization. So each of these stages, the microscopic features are different. Okay, but for your examination purposes, most of the times you will be given stage of gray hepatization, which I'll be discussing in detail. Stage of congestion, what will you see? You see basically the congested capillaries in the interstitium, and the alveoli is filled with fluid. You can find some bacilli here and there. That's stage of congestion. Stage of red hepatization, you find RBCs predominantly in the alveolar lumen, whereas stage of gray hepatization, after a few days, the neutrophils are replaced by the macrophages. In stage of red hepatization, you find RBCs and neutrophils in the lumen, whereas in the stage of gray hepatization, you find neutrophils and macrophages in the gray hepatization stage. Okay, and what is important to note that you find a clear space between the collection of inflammatory cells and the alveolar wall and the alveolar lining. That's very important because the exudate is now being organized. That's the stage of gray hepatization. Whereas in the stage of resolution, almost all the inflammatory cells are taken off or devoured by the macrophages, and it comes back to normal. The lungs, the alveoli looks normal in stage of resolution. So if you want to illustrate, as I told you, what you will get is most often the stage of gray hepatization, where you need to demonstrate that the air spaces are filled with exudate. Exudate meaning collection of neutrophils, and also along with exudate you also should see macrophages. Okay, this is the alveolar lining epithelium. You can find the neutrophil rich exudate. Along with neutrophils you also see histiocytes or macrophages. Okay, and as I told you, the space between the alveolar lining and the infiltrate, that's very important because you are essentially telling that there is organization of this exudate within the alveolar lumen. So that is very important. And then you can show the septa with few congested blood vessels. So I hope you have understood the concept of writing lobar pneumonia illustration, right? So make sure that you write the alveoli properly and then fill in the neutrophils and histiocytes along with showing space between the alveolar lining and the exudate. So that is the stage of lobar pneumonia, gray hepatization stage. Moving on to the next slide, chronic cholecystitis, where you will be demonstrating the features of chronic inflammation here. Okay. Till this time, we talked about acute inflammation in terms of acute appendicitis and lobar pneumonia. Now we will move on to chronic cholecystitis. Gallbladder, how do you identify? It has mucosa, which is composed of lining epithelium made up of columnar epithelium, right? So that is mucosa. You do not have submucosa in the gallbladder. So it's a seromuscular layer straight away. So what you see in chronic cholecystitis, one, identify the mucosa, and then there is outpouching of the mucosa into the underlying muscular layer, seromuscular layer, and these are known as Rokitansky-Aschoff sinuses. Because we are talking about chronic cholecystitis, you should demonstrate chronic inflammatory cells in all the layers of the gallbladder, right? So these are the mononuclear cell aggregates. All those blue collections, they are actually mononuclear inflammatory infiltrates, which are basically lymphocytes and plasma cells. You can also see subserosal fibrosis. Okay, that's the feature of chronic cholecystitis. Can you make out the mucosal epithelium, which is columnar, okay, mucin secreting columnar epithelium, and these are the Rokitansky-Aschoff sinuses. Basically, they are the outpouchings of the gallbladder mucosa, into the muscularis, inward extension of the mucosa into the muscularis. These are the mononuclear cells in the layers of the gallbladder. So, identify the mucosa, demonstrate the Rokitansky-Aschoff sinuses, and most importantly, chronic inflammatory cells in all the layers of the gallbladder. Illustration is very, very simple. Write the mucosal lining, talk about the Rokitansky-Aschoff sinuses here, and then most importantly, mononuclear cell infiltrates in all the layers. If it is too long a duration of chronic cholecystitis, you can also see fibrosis in the serosal aspect, or the subserosal fibrosis you can demonstrate. So that is about chronic cholecystitis. Next slide which we will be discussing is tuberculosis lymph node. One of the easiest slide you can get is TB lymph node. All you have to see is caseous necrosis in the center of the lymph node. Okay, what is this caseous necrosis? These are amorphous eosinophilic dendritic material. Okay, amorphous granular eosinophilic dendritic material. That's what is called as caseous necrosis. Caseous necrosis is not a microscopic term. Okay, it's just a necrotic material. Caseous meaning cheesy. This is a macroscopic term. What you see in the cut section of the lymph nodes involved by tuberculosis, it is caseous. That means the necrotic material looks like a cheese. Caseous means cheese-like. That's why it's called caseous necrosis. So we need to ideally avoid the term caseous necrosis on microscopic description. Okay, because all you have to say is that amorphous eosinophilic granular necrotic dendritic material. Simple. Around the caseous necrosis is what you find these classical cells, and these classical cells are called as epithelioid cells. Okay, epithelioid cells are basically the modified macrophages. Okay, they are modified to tackle the tubercle bacilli. They look like an epithelial cell. That's why it is called epithelioid cell. So you find these sheets of epithelioid cells around the caseous necrosis or around the necrotic material. Sometimes these modified macrophages fuse together to form a giant cell. Okay, and this giant cell is referred to as a Langerhans giant cell. Don't get confused with Langerhans cell. Langerhans cell is found in the epidermis. They are a type of dendritic cell, whereas Langerhans cell is a cell which is a giant cell which is seen in tuberculosis. Okay, most often students get confused with Langerhans and Langerhans cells. So this in tuberculosis is a Langerhans type of giant cell. So around the collection of histiocytes and the giant cells is cuff of lymphocytes and plasma cells. Okay, so you find a collar of lymphocytes surrounding these epithelioid cell aggregates, and this whole thing is called as a granuloma. Okay, so basically if you want to define granuloma, granuloma is a collection of modified macrophages, that is all. And these granulomas can have necrosis, may not have necrosis. Classically in tuberculosis, you will have necrotic granulomas, and that necrosis, grossly it is caseous necrosis. So that's all about tuberculous lymphadenitis. Much easier to diagnose tuberculosis on microscopy. Next one is granulation tissue. Very important slide which most students gets confused with either capillary hemangioma or a granulation tissue. So I'll try to differentiate how granulation tissue looks on microscope. Very classical picture of granulation tissue. All you have to see is thin-walled capillaries. Okay, almost the whole slide will be having these thin-walled capillaries. Why do I say thin-walled? Because it is only lined by a single layer of endothelium. You have few RBCs inside the capillaries. So you find multiple thin-walled capillaries of variable sizes. Second important component of granulation tissue is the fibroblast. Because you know that granulation tissue has two components, angiogenesis and fibrogenesis. Angiogenesis is demonstrated by the presence of thin-walled capillaries, whereas fibrogenesis is demonstrated by the presence of spindle-shaped cells, they are fibroblasts. And another important aspect of granulation tissue is the presence of inflammatory cells. Okay, this is a hallmark of inflammation, chronic inflammation. So you have to find the inflammatory cells. And what are these inflammatory cells? It can be acute to chronic. Okay, most often they're all histiocytes, lymphocytes, plasma cells, and histiocytes. Sometimes neutrophils can be seen. These are the inflammatory cells. Demonstration. Writing a granulation tissue is much simpler. Write these proliferating capillaries, show these thin-walled capillaries with single layered of endothelium. Show those mixed inflammatory cell infiltrates. When I say mixed inflammatory infiltrates, write lymphocytes, plasma cells, neutrophils, eosinophils, and macrophages. And the second component of granulation tissue, as I told you, fibroblasts. Okay, demonstrate those spindle-shaped cells in between, showing that you're actually talking about fibrogenesis. So fibroblast with or without collagen production. Initial stages you don't find collagen production. Later stages, yes, it can be, collagenization can happen. And the stroma in the early stages is always edematous. Just have a loose edematous stroma. How do you show loose edematous stroma? All you have to write chronic inflammatory cells here and there. That's all. That's how you write granulation tissue. So how is this different from a capillary hemangioma? Capillary hemangioma is a tumor of blood vessels, you know that. They are also composed of capillary sized blood vessels. Okay, but they are lobulated. Okay, it's confined, lobulated collection of capillary sized blood vessels. But one important thing you need to remember is that you should not find inflammatory cells in the stroma of capillary hemangioma. Got this point? So it has to be no inflammation, unless and until capillary hemangioma can also be infected. That is a different issue. But then by and large, you should not find inflammatory cells in the slide of capillary hemangioma. So if you find inflammatory cells, if you find lots of capillaries, straight away think that it is a granulation tissue. It's very simple. Thank you for watching. I hope these slides, the description of these slides made some sense to you people. I will come out with a few more slides in the next session. Till then, stay tuned. Bye-bye.